So my name is Sherwin Fernando. I'm a current F1 in West Midlands, and I'll be presenting pyrexia and sepsis in the adult patient. Pyrexia and sepsis can present in both new admissions and in current inpatients. And one of the most common beliefs we get as an on-call F1 is, doctor, this patient is spiking a temperature. If I were to break down sepsis and fever to the most simplest basics, fever is the body's response to inflammation. And inflammation is a pathological process which can lead to SIRS, systemic inflammatory response syndrome. Now, if you're not familiar with it, you will be very soon as a house officer. The News 2 chart, which can be a very effective means of early triage and of appreciating how sick a patient is. But if we were to go through it, patients with fever or with sepsis will typically present with an increased respirate, a tachypnea of greater than 25 resps per minute. They may have a new oxygen requirement or an increasing oxygen requirement if they're already on oxygen, and may require additional supplemental oxygen, which more often than not will be put on by nurses as and when the patient needs it. Naturally, patients will have an increased temperature, but some patients will present with hypothermia as well. And the patient will drop their blood pressure, typically a hypertension of less than 90 millimeters of mercury systolic, or a drop greater than 40 from their baseline blood pressure. You'll often see temperature spikes presenting with associated tachycardias. When you're looking at the observations, the news charts for patients, it's always important to look at the trend. Does each spike accompany a tachycardia? Is the spike consistent? Or are there particular times of day where the patient is spiking? And of course, the patient may have a reduced level of consciousness, again associated with their sepsis or potentially with septic shock. In addition to the news chart, there are other considerations. The patient may have what's called an acute oliguria. That is that they've not passed any urine in the last 18 hours, or they've passed less than half a ml per kilogram per hour if this patient has been catheterized. The patient will have a delayed cap refill and potential skin changes such as mottling or an ashen appearance. Associate all of this and correlate all of this with the patient's laboratory findings, and you'll find that your patient may have sepsis. Severe sepsis is an outdated term, but essentially describes the parameters that I've mentioned that have been upset and require medical intervention, which you'll be expected to do on the wards. Septic shock, however, is a patient who's been diagnosed with sepsis with persisting hypertension, requiring a vasopressor support to maintain a mean arterial pressure greater than 65 millimeters of mercury. Or what you'll see more commonly is that this patient persistently has a lactate above 2, despite your best efforts to fluid resuscitate. This is a very simple slide, but the most common sources of infection are in the lungs and the urinary tract. And of course, bacteria are the most common causative organisms. But you also have to remember the more niche causes such as infective endocarditis, meningitis, TB, SBP, and cholangitis. A patient who's either septic or pyrexial can also be driven by viral infections, either upper or lower respiratory, but also think about your hepatitis. Of course, parasites and fungus can cause sepsis and can cause fevers, and this, particularly the fungus infections, are particularly more common in patients who are immunosuppressed. Let's take a brief moment to explore in detail the Sepsis 6 protocol. Traditionally, this was 3 in, 3 out, but significant amount of research has been done into Sepsis 6, and it's now a stepwise process. When you're called to see a patient, you need to perform an initial ABCDE assessment. And upon diagnosing sepsis, you would begin your protocol. Now, it's important to remember that sepsis proforma is available throughout all trusts, and if not, the sepsis proforma from the National Sepsis Trust can be downloaded online, and a link will be included in the cheat sheet for this particular presentation. But the 6 are senior escalation, oxygen if the patient requires it, aiming for target sats of 94 to 98% or 88 to 92% if the patient retains CO2. Remember that now it is known that hyperoxemia, overoxygenation, can also be detrimental to patients, so you have to be sensible. Oxygen is just like any other drug that you prescribe. Establish IV access and get bloods. Ideally, this is large bore, a pink or even a green cannula. And you need to take blood cultures, a blood glucose, lactate, full blood count, U's, CRP, and clotting. Also, if the resources are available and you are trained and signed off, consider a lumbar puncture if the patient needs it. Don't delay initiating your IV antibiotics, and this will be dependent on local guidelines, but aim for broad spectrum. Think whether this patient might need antivirals, but always check the patient's allergies. Sometimes patients might already be on antibiotics, in which case you consider an IV switch or consider escalation of antibiotics to something more broad spectrum. Resuscitate with a 500 ml bolus of IV fluids, but consider a more cautious approach if the patient has heart failure, a 250 bolus, for example. Remember that nowadays you should take serial lactates every hour initially, and use your serial lactates to guide the intensity of your fluid resuscitation. The final point is to monitor your patient through the news score, through their urine output, and always discuss these patients with a senior. Septic patients, those in shock, will need to go to ITU. Remember that all of this should be done within the hour. This is the copy of the sepsis pro forma that I mentioned, available on the Sepsis Trust website, but similar things will be available throughout your trusts. The clinical examination for pyrexial patients is very simple. You need to be searching for a potential source, be it the chest, the urine, the abdomen, any foreign bodies. Past medical history and previous infections are particularly important. In terms of past medical history, particularly if the patient has any foreign bodies, any metallic valves, if they're on any long-term immunosuppression, and previous infections, you're thinking about anything reactivating. Travel history is always good to take to ensure that you don't miss the more niche causes, as well as recreational drug use, and a full drug history, again, to ensure that your patient is not immunosuppressed, and to ensure that you're not giving any medications that can interact with your antibiotics. In terms of examination, it is important to examine all systems to rule out any sources for their fever. Also ensure that you're checking the skin for any signs of cellulitis or any abscesses. If we divide investigations, your initial investigations should include bloods and blood cultures, as mentioned as part of the Sepsis 6 protocol. Urine dip and urine cultures are important, but sometimes remember with elderly patients, if you dip their urine, they have asymptomatic bacteria, in which case taking cultures and correlating clinically is more important, as well as a chest x-ray to rule out any consolidation. I've listed here more complex investigations that you want to consider if your initial investigations aren't yielding anything. Particularly think about stool cultures, lumbar punctures, echocardiogram if you really can't find any source of infection, abdominal imaging, and if all else fails, sometimes a PET scan is used to determine the source of infection. In terms of antibiotics, the advice will always be the same. Follow your local guidelines and never forget to check allergies. You should consider the patient's baseline renal function when dosing, and consider renal dosing if this baseline is deranged. Certain antibiotics will need to be monitored. This can be something simple like daily use and ease, or more complex like trough levels. The most common spring to mind being vancomycin and gentamicin. Consider C. diff risk as well, particularly if your patient's having loose stool and is on antibiotics. And always ask the question, are you controlling the source of infection? There are non-infective causes of pyrexia, which we'll go through quickly. Your autoimmune conditions such as rheumatoid arthritis, IBD, allergy, and also transfusion reactions. In addition, certain malignancies, B symptoms, and certain granulomatosis conditions can also cause pyrexia. The most common drug we see causing pyrexia is ecstasy. Thank you very much for listening to my presentation, and best of luck on your new jobs.